Well, I'm very excited to be here, and I'd like to thank Evelyn and the committee of the Narcolepsy Network for inviting me to come along and speak. I hope everyone here is excited to be here. This is a fantastic meeting. I was looking at the program, and for the speakers that are going to be following me, I mean, you're really going to get exposed to some of the world's best people in research and in clinical narcolepsy. So you've got a great opportunity to hear fabulous people speak to you during this conference. So I thought, when I was asked to speak, what am I going to speak to you about? Obviously, at this particular meeting, as it's a patient meeting, you don't want to hear things in too much detail and depth from a research point of view. And I thought, well, what's new that you might want to hear about? And I thought a big change is sort of coming with regards to the diagnosis of narcolepsy. And as the majority of the people in this audience have narcolepsy, of course, you probably will want to know, well, where do you sit in terms of the new diagnostic criteria that are coming out? So I'm going to talk quite a bit about the new diagnostic systems that are out there. And then I'm going to touch a little bit on pathophysiology. I'm not going to go into this in much detail because Dr. Siegel immediately after me is going to be talking about that. Dr. Scammell, who's coming, is going to be talking probably about that as well. And then I'll touch a little bit on treatment and some of the new treatment directions, some of the subsequent speakers are going to be talking about. So in a way, my talk will set the stage in terms of the pathophysiology and treatment to things that you will hear in greater depth as we go through this program. Okay, so first thing I wanted to show you is that there's a lot of interest now in trying to recognize narcolepsy. Many people think that narcolepsy is a rare disease, and I suppose it is. I mean, 50 to 100,000, probably quite rare in the general population. But as I tell specialists in sleep medicine, when you're faced with a patient who has sleepiness, it's not a rare condition. Because when you narrow it down to people that actually have a major complaint about sleepiness, then it's not so rare narcolepsy. And if physicians don't think about it, of course they don't make this diagnosis. And one of the problems is that there is a long time from the onset of the symptoms of narcolepsy to the time of diagnosis. And I know many of you are aware of that. I mean, studies have shown that most people that get diagnosed with narcolepsy have seen at least 2 physicians prior to the time that they get their diagnosis. And those physicians have not recognized the fact that they have narcolepsy. Now, this is some information on nearly 1,000 patients with narcolepsy that we analyzed some years ago. And I think what I want to show you here is there is a couple of peaks here. You can see the blue lines. That's the time of onset of narcolepsy, and the red lines are the time of diagnosis. And what we found looking at 1,000 patients with narcolepsy is that the peak time of onset of symptoms, in this case, the median time was 16 years of age. So it meant that half the people had symptoms before 16 in childhood. But when you look at the number getting actually diagnosed in the red bars, you see very few people get diagnosed in childhood. Now, it is getting a little bit better because physicians are becoming more aware of narcolepsy, but still many, many children don't get diagnosed when they first have their symptoms. And of course, this is such a crucial time because education is being affected because of the symptoms of narcolepsy. So if people aren't getting diagnosed until here, as in this sample of patients, the median time of diagnosis was 33. So very, very much later. Now, we're doing somewhat better, and I've just been involved in a publication where we've analyzed all the information with regards to delay in diagnosis of narcolepsy. So we've looked at this data. It appears as though diagnosis is getting a little shorter, but even so, even now in 2013, there are many people who have the symptoms of narcolepsy, and it's going to take many years before they get diagnosed. So we need to do better in terms of the medical profession in trying to recognize people who have narcolepsy, particularly in these crucial first 2 decades of life. Now, one of the things that obviously influence diagnosis is the diagnostic criteria. There we go. Okay, and there are 2 major diagnostic criteria that are out there that physicians will tend to use. And one is by the American Psychiatric Association, and this was just published recently. This is the Diagnostic and Statistical Manual of the American Psychiatric Association, the DSM-5. And these are the criteria that are included in the DSM-5. It's a little unfortunate that we tend to have 2 major diagnostic criteria sets for narcolepsy. The other one is the International Classification of Sleep Disorders, and they're just undergoing a revision. Their new classification system was supposed to be released in October of this year, but it's not going to be released now until the beginning of next year, so it's still a little bit off. And what I'm going to do is I'm going to show you those new diagnostic criteria, but bearing in mind that it's not published yet and there could well be changes before those diagnostic criteria are actually finally sort of printed and cast in stone. But let's go through this, and some of you will like to see, I'm sure, how you fit in amongst the new criteria for narcolepsy. So the first criterion for narcolepsy is recurrent episodes of irrepressible need to sleep, lapsing into sleep, or napping within the same day. And this is pretty typical. I think everybody, 100% of patients virtually with narcolepsy are going to have sleepiness that's present every day. And that's one of the big hallmarks of narcolepsy, is that the sleepiness doesn't go away. It's there in some form. Admittedly, there may be fluctuations, and you're all aware of that. Some days you're going to be worse, other days you're going to be a bit better, but it's never going to be totally eliminated. And so people who have sleepiness on an everyday basis, one has to consider the possibility that narcolepsy is a cause of that. The criteria say that it must be present for at least 3 months and must be occurring at least 3 times a week. Well, of course, and as I just mentioned, most patients are going to have it every day of the week. It's not going to be just 3 days a week. But the 3 months is a little bit difficult. There are some patients who have fairly sudden and acute onset, and some of you here might have had that, of sleepiness, that it may actually occur within a few weeks, not months. So if you've got to wait 3 months before officially you get a diagnosis, that sort of delays things. But this is consistent in the psychiatric manual with so many other disorders, that they have this 3-month limitation on the main symptoms before you can be actually diagnosed as having a particular disorder. So if you see somebody within a few weeks of onset and they don't give you an official diagnosis of narcolepsy, it might be because you're within this 3-month period of time. Now, the other criteria in this manual for narcolepsy are the presence of at least one of the following. And I'm going to show you several different items here. The first item is cataplexy. And in their criteria, in the psychiatric manual, they actually define what cataplexy is. And they say either A or B. In A, they say in individuals with long-standing disease, and they classify cataplexy as brief, seconds to minute episodes of sudden bilateral loss of muscle tone with maintained consciousness, so people are aware of the environment, and that it's precipitated by laughter or joking. Now, this essentially comes from research that was done at Stanford University. What they did was that they took questions about what precipitated or what caused cataplexy, and they looked at all these different emotions that might cause cataplexy. And what they found was that the most sensitive thing in producing cataplexy was hearing or telling a joke. And a lot of positive type of emotions like laughter, tended to the elation, excitement, tend to be a cause for cataplexy. But we know that it's not just caused by that. There are people who have negative type of emotions. Anger may cause cataplexy. So the range of emotions is very, very large. But in the diagnostic criteria, they've just pulled out this laughing and joking as being two of the major emotional causes for cataplexy. Now, they have here A and B, and in B they specifically say in children or in people within 6 months of onset, there can be things other than this bilateral loss of muscle tone. There can be grimaces, jaw-opening episodes with tongue thrusting, or global hypertonia, which means that a generalized weakness, and without any emotional triggers. So they're recognizing that at the early stages of narcolepsy, there may be cataplexy that's present, but it's not produced by emotion. Not produced by any emotion. And this, I'm not quite sure why they've particularly separated this out to 6 months of onset, because it's not uncommon for people who have had narcolepsy for many years, and I'm sure many of you have experienced this, that you can get cataplexy even though there is not a particularly strong emotional trigger. So that, for example, when you're sleep deprived, there can be a strong pressure for REM sleep, for dreaming sleep, and you may be very tired and sleepy. And then for very minor reasons, and it may not be clearly an emotional trigger, you may get an episode of cataplexy or weakness. And it's more likely to happen when you're extremely tired or sleepy. So it doesn't just happen. Sometimes these episodes of weakness can occur even though there isn't any strong episodes of emotion. They also mention here about jaw opening. One of the problems, I think, with narcolepsy is that in the books, what we tend to read about is this up here. We read about this bilateral loss of muscle tone, and this is what most physicians think. They think that patients with narcolepsy, if they get excited or get some emotion, they fall to the ground. And they're not aware, most physicians are not aware of other manifestations of cataplexy. And they think, well, if the patient doesn't fall to the ground, they can't have narcolepsy. But of course, we know that that's ridiculous, that there are many other types of manifestations. And in children, it's very common for them to have this jaw opening, so that the jaw weakness can occur with the mouth opening, the tongue coming out. Actual thrusting of the tongue, personally, I'm not so sure about that, but obviously it must have been noticed for them to actually mention this, but I'm not sure about the thrusting. In most cases I'm aware of, when people get cataplexy and their jaw opens, the tongue becomes weak and it just tends to flop out of the mouth and so may protrude a bit. But the grimaces, a lot of physicians don't realize that facial changes can often give the diagnosis of narcolepsy. And minor twitches in the facial muscles, and I'm sure some of you have this, can occur as you're sort of going into a cataplectic episode, or even maybe just a partial manifestation and you don't get full cataplexy. So you can see it in the face, little twitches in the muscles. And it's one of the features of cataplexy in patients with narcolepsy that can occur that many physicians are not aware of. Okay, so now, as I mentioned, you must have, for this criteria, you must have sleepiness, then you must have either the cataplexy or one of these other things. And the other two things are hypocretin deficiency. I know many of you are aware of hypocretin and what it is, and most of you won't. I know subsequent speakers are going to be talking about it in more detail. I will mention it a little bit in my talk. But this is a neuropeptide that we know in patients who have narcolepsy and cataplexy tends to be reduced or absent in the brain. And just simply, we currently understand that narcolepsy is an autoimmune disease, that there's loss of hypocretin cells in the brain, and as a result, if you measure cerebrospinal fluid looking for this neuropeptide, hypocretin, it's either very reduced or it's absent. So the second criteria is that if you don't have cataplexy, but somebody has a spinal tap and they have this low level of this substance hypocretin in the fluid, spinal fluid, that's sufficient to make a diagnosis of narcolepsy. Now, of course, most people don't get this measured. There are very few places in the country that measure hypocretin, and it involves the spinal tap. And I'm sure if I'm going to ask you who wants to volunteer for a series of spinal taps, I'm not going to get too many of you putting up your hands, right? So it's not a very pleasant experience having a spinal tap, so most people don't want to have that done. So most people don't get this, and despite the fact that there isn't a universal national assay for this, or measurement for this hypocretin, it's only done at a few select specialized centers around the country. But despite that, some people have had this done, and if you have it done and it's very low, that plus 3 months or more of sleepiness is sufficient to consider a diagnosis of narcolepsy. So I've put in here the exclusion that there is any other brain disorder going on, but we do recognize that this can be low due to other brain reasons. So there are a number of other neurological disorders that can reduce the level of hypocretin as well, but most commonly it is associated with narcolepsy. Now the third item is having sleep studies, and I'm sure virtually everybody here who has a diagnosis of narcolepsy has had sleep studies. And in the sleep studies there is a major change that's coming, that's presented here and presented in the new International Classification of Sleep Disorders too. So typically what we've had is that somebody would have a nighttime sleep study, which I'm sure you've all had, to make sure that you don't have anything else causing you to be sleepy, like sleep apnea. And then you have a daytime test looking to see if you have sleepiness during the day, and if you go into the dreaming sleep or the REM sleep. And typically what's been shown is that people will fall asleep quickly, and the criteria are 8 minutes or less on that daytime test, and will go into the REM sleep on at least 2 out of 4 or 5 naps during the daytime. So that's been the classical criteria for narcolepsy. But now, in this, what is the major change here is that on that nighttime sleep study, if somebody goes into the REM or dreaming sleep very quickly, in less than 15 minutes, then that can be diagnostic for narcolepsy without having the daytime test. So what they're saying here in this criteria, and I'm not entirely comfortable with this, is that somebody who is sleepy, who has a sleep study, and falls and goes into the dreaming sleep within 15 minutes can get a diagnosis of narcolepsy. You don't need the daytime test. So that's a major change, and there are some other conditions in medicine that actually can do that, make people sleepy and cause them to have an early onset of REM sleep. So it may give a little bit of diagnostic confusion as we go forward. But I think that despite that, what we're going to find is that the majority of people with narcolepsy will have the nighttime test. They may have this going into REM sleep very early at night, but then they'll also have the daytime test, and they will have sleep onset REM periods during the daytime test. And I'll mention to you how in a few minutes, how the International Classification of Sleep Disorders handles this issue. So those are the criteria: sleepiness plus one of those three, either cataplexy, the loss of this neuropeptide in the spinal fluid, or having the sleep study criteria. Now, in the DSM-5, what they do is that they also present variations, what they call subtypes of narcolepsy. And what they're saying here is that some people have narcolepsy, they don't have the cataplexy, but they have that hypocretin deficiency. Now, this still meets that criteria that I just talked about, but they regard that as a subtype. So people who just have the sleepiness and the abnormal low level of the neuropeptide can have narcolepsy. That's one subtype. And then there's narcolepsy with cataplexy, but people who don't have an abnormality of that neuropeptide in the CSF. Now, most people who have cataplexy do have a loss of the hypocretin. Most people do, but there's a small percent, and they're saying here about 5%, of patients who have cataplexy that do not have a low level of hypocretin, so the hypocretin level is normal. And if so, they give this a second sort of subcategory here. Then there's a third subcategory they talk about: autosomal dominant cerebellar ataxia, deafness, and narcolepsy. This is a form of cataplexy associated with postural control abnormalities, because part of the brain called the cerebellum, so that people are not steady on their feet, they have what's called ataxia. But they also have loss of hearing, and they have narcolepsy. Now, personally, I've never actually seen a patient with this. In fact, if there is anyone here in this audience who has this, I'd be happy to meet with you afterwards, because I've never seen this type, although it is well described in the literature. So there may well be some people here who meet this particular criterion for narcolepsy. And it's associated with a genetic abnormality that's been documented. Okay. There are a couple of other subtypes, if I can get to them. Okay, another subtype that's being recognized is people that have narcolepsy being overweight, being obese, and having type 2 diabetes. I suspect this is more common than the previous type of narcolepsy. And again, some of you may fit into this particular category of having diabetes, being overweight, and having narcolepsy as well. And then the final category is that category where people may have had some neurological illness of some type or disorder that has in fact precipitated narcolepsy. And this can be a whole variety. A few examples are listed here that can cause this. More likely to happen actually in people that are older, that may have some brain lesion due to stroke or some other cause. But it's recognized, and there is a whole very large list of different disorders, neurological disorders, that can cause narcolepsy. So in most cases, narcolepsy due to the loss of hypocretin only, and people don't have other neurological disorders, but there are some people who will have a neurological disorder associated with their narcolepsy. So that's a different category. Again, some of you may fall into this classification. Okay. They also give criteria for severity of the narcolepsy. Now, I'm sure many of you are going to disagree with it. I somewhat disagree with it, actually. But I guess it's an attempt to try to categorize narcolepsy as being mild, moderate, or severe. So the mild form is infrequent cataplexy, classed as less than once a week, but it doesn't define the type of cataplexy. So for somebody, it may be just a drooping of the head. For another person, it may be falling to the ground. And the need for naps once or twice a day, and not so much disturbance of nighttime sleep. And they regard this as being mild. Moderate is cataplexy once a day, or every couple of days or so. Disturbed sleep at night, and the need for naps frequently during the daytime. And then severe, they categorize as drug-resistant cataplexy. Now, with our newer medications, there are not so many people now that fall into this category, because most people with the newer drugs tend to respond in terms of the cataplexy to the drug. So I'm not quite sure why. I personally wouldn't have made this drug resistant. I think cataplexy can be severe even if it's completely controlled by medication. So some people may have very, very severe cataplexy that occurs multiple times a day, and but it may be controlled by drugs. So they have these. It's an attempt in the manual to try to categorize the severity, but personally, I'm a little dubious about these categories. In the new International Classification of Sleep Disorders, which is the main category, diagnostic category used by sleep specialists, there are some changes that are occurring in the new classification. we used to have narcolepsy with cataplexy as a diagnostic category. That's been changed. It's now called narcolepsy type 1. And people that don't have cataplexy is called narcolepsy type 2. Now, I know there's going to be some question and concern about this, because my only concern about this is that narcolepsy, when you state narcolepsy with cataplexy, it's pretty clear to people what that is, and to other physicians. If we're now going to start saying narcolepsy type 1, so many physicians are not going to understand what that means. So many physicians don't understand the details of narcolepsy anyway, and now if you're going to start calling it a type 1 and a type 2, I think it's going to cause some confusion out there. I'm not sure how you as patients like the fact that you're now labeled as narcolepsy type 1 or narcolepsy type 2, because this will be your new diagnostic category. And I'll explain exactly what these mean in a minute. The other, under the hypersomnia disorders in the new classification, they now call idiopathic hypersomnia just idiopathic hypersomnia. There may be some of you who have received that diagnosis that are at this meeting, where there is sleepiness present every day, just like narcolepsy, but they don't have the REM or dream phenomena like narcoleptic. And it used to be divided into short amount of sleep at night or a long amount of sleep. So idiopathic hypersomnia was long sleep time, and idiopathic hypersomnia was short sleep time. But they've gone back to the simpler category of lumping everyone together as just idiopathic hypersomnia. And then what used to be called recurrent hypersomnia, and there were different forms of it. They've gone back to the original terminology of Klein-Levin syndrome, where people have severe sleepiness that occurs and is present for a matter of several days or weeks at a time, and occurs several times a year. So recurrent bouts of severe sleepiness, in between which the patient is essentially back to normal. So there are some major changes in the diagnostic categories now of disorders of sleepiness. Okay, so this is type 1. So in type 1, again, the patient has irrepressible need to sleep, so uncontrollable sleepiness, present for at least 3 months, just like the psychiatric manual category. And it's mentioned here that in young children, narcolepsy may sometimes present with a long nighttime sleep or resumption of previously discontinued daytime napping. So they've put in a little provision there for helping to diagnose narcolepsy in children. In children, in the diagnostic testing, and I've just put it on this slide, but it's recommended that they should have actigraphy now in making the diagnosis. Actigraphy is a little thing like a wristwatch, goes on the non-dominant hand, and it measures rest and activity. And what it does is those rest and activity periods equate with sleep and being awake. But you can measure it over a period of weeks. So it's a simple thing, and the reason for this is partly because children, of course, can't pull out a sleep diary or a sleep log showing when they sleep and when they wake up. And getting this can show if there's a lot of variation, because some children can have a great amount of variation in their sleep pattern. Okay, so in the new categories, they've got of the International Classification of Sleep Disorders, they have the presence of 2 or more of the following. First one is cataplexy, not actually defined in the criteria, but it's defined in the manual itself, how you diagnose cataplexy. The second item is the sleep studies. Now they're a little bit different than the psychiatric categories here, in that they recognize the MSLT features for the diagnosis, so falling asleep quickly and going into the REM sleep during the daytime. And they also recognize that you can fall asleep into REM sleep on a nighttime study. So what they're saying is that if you fall asleep on the nighttime study, that's counted as one episode of REM sleep. You don't require 2 on the multiple sleep latency test. But in the sleep disorders classification, they do require having both the nighttime sleep study and the daytime study. They did not require that in the psychiatric manual. Just the nighttime study could have been useful. So here, if you fall asleep and go into REM sleep at night, and on the daytime test only have one episode of REM out of 5 naps, that's sufficient to diagnose narcolepsy. So that is a change. So it's not necessarily needing 2 on the daytime test. If it's mentioned also, and this is very important for insurance purposes, I think, because sometimes people with narcolepsy don't meet these criteria on the first testing, and I'm sure this has happened to many of you out there, that the test has been negative the first time, and so they've added in here that if narcolepsy is suspected, that the test should be repeated. So if you've had a negative test and you've only had it done once, here they're recommending that you get the test done again to see if it becomes positive. So in some people, the test may be negative the first time. Now the third item is that hypocretin again in the cerebrospinal fluid. So in the international classification, you need sleepiness and you need at least 2 of these. So you can either have cataplexy and the sleep study, or cataplexy and the hypocretin level. Okay, so in this form, then this is the new term is narcolepsy without cataplexy. Narcolepsy with cataplexy for the type 1. And we're starting to cataplexy has always been a problem in terms of diagnosis, because for many people who have cataplexy, physicians, even experienced sleep doctors, can't recognize cataplexy the first time. And the patient themselves may not be aware of the symptoms. So we're starting to sort of educate physicians more about cataplexy. And a lot of it's mentioned on this slide, in particular mentioning the changes in the head. Getting away, as I mentioned earlier, talking about the falls to the ground or the weakness in the legs. But there's a lot more emphasis on the facial and head features, the slurred speech, the jaw opening, the drooping of the eyelids, the drooping of the head, etc. So cataplexy is still a very important symptom, and one that is most often missed by physicians who are not experienced in narcolepsy. Now I'm going to move on to histamine and pathophysiology. I mentioned about hypocretin, but then there is some new data, and Dr. Siegel's going to be talking about this. This is from some of his work looking at part of the brain by the hypothalamus called the tubomammillary nucleus. And up to this time, we've always thought the only change that you can find in the brain is the loss of these hypocretin cells. But now it's recognized that there is an increase in histamine cells. And that if you look in this particular nucleus called the tubomammillary nucleus, you find in patients with narcolepsy and brain tissue that there is a high number of histamine cells compared with controls. So this is another quite specific abnormality associated with narcolepsy. Now, why these are increased is not known. I mean, it is suggested that this may be a secondary response to being so sleepy, trying to drive these cells to produce this wake-promoting neurotransmitter called histamine. So it may be a secondary response to the hypocretin loss. But again, Dr. Siegel will be talking about this in more detail. We have known for quite a while that if you measure this in the cerebrospinal fluid in patients with narcolepsy, that it's low. This is a complex slide, but basically up here you have the normal distribution, and in these groups of patients with narcolepsy and idiopathic hypersomnia, the CSF histamine tends to be quite low. So that's been known for some time. So although it's low in the spinal fluid, the cells themselves in the tubomammillary nucleus are increased. I'm sure Dr. Siegel is going to explain why that is. Okay. Genetics. We know genetics is very important in narcolepsy. It's been long recognized that there's this feature, the histocompatibility antigen in narcolepsy, which has been found in patients with narcolepsy. First, 100% of Japanese narcoleptics had these changes in this, or had these histocompatibility findings. And then over the years it was recognized that this particular allele, the HLA-DQB10602, is very much associated with narcolepsy. But African Americans tend not to, or African Americans have that, but they tended to not so much just have the DR2 positivity. But 100% are positive for this HLA-DQB10602. So this is now the histocompatibility allele that is measured in many patients, not necessary for the diagnosis, so you didn't see it there in the diagnostic criteria. And most patients with narcolepsy who have the loss of this, who have this HLA-DQB10602, have a loss of the hypocretin. So hypocretin deficiency. So it goes along, these two things go along together. There are other histocompatibility antigens that are found in patients and found in people that tend to be protective for narcolepsy. So people that have this, the DQB10601, tend not to have narcolepsy. So although we know that this one is associated with narcolepsy, there are others that seem to be somewhat protective from getting narcolepsy. Okay. There is another genetic abnormality that's a genetic finding in narcolepsy, and that is this particular gene, the T-cell receptor alpha gene. And there are abnormalities in this T-cell receptor alpha gene. And the important thing about this T-cell receptor alpha gene is that it interacts with the HLA process. It tends to be involved in turning on cells that may cause destruction of these hypocretin cells. So there are these two particular findings, the HLA and the T-cell receptor alpha gene abnormalities that are found in patients who have narcolepsy with cataplexy that may be very important in setting the stage for the occurrence of narcolepsy. But something else, many people may have these two genetic findings but not have narcolepsy, so there's something else that has to come along and set it off. And current feeling is that it may well be an infective condition. There are some studies showing that if you go close to the onset of the time of narcolepsy, people are more likely to have antibodies to Streptococcus, suggesting that a streptococcal infection might have precipitated the narcolepsy. And there are a couple of studies that have shown us. I think Dr. Swick's going to talk a little bit more in detail about this. Okay. This is another study, again, by another group, showing again streptococcal antibodies being associated with narcolepsy. Okay. There has been a recent finding that some of you may not be aware of that I just want to bring your attention to, and again, other speakers will go into this in more detail. But in Scandinavia, there's been an increase in patients with narcolepsy. And it occurred, as you can see from these graphs, around 2009, a sudden big increase, particularly in children, less commonly in adults. And this followed the H1N1 pandemic of that virus. And what they discovered was that initially they thought that it was the virus causing the increase in narcolepsy, but subsequently they recognized that it was actually due to the vaccination that they got. And what happened in Scandinavia is they got this particular type of vaccination called the Pandemrix, and had this particular adjuvant associated with it. Now what an adjuvant is it's a substance that you mix with dead or attenuated viral particles that causes an increased immune response. So when you give a vaccine, you get an increased immune response. This particular adjuvant wasn't used in the United States, but it was used in in Canada and in Scandinavia. And they particularly found an increase. So the latest that I heard the other week is that they have now over 200 cases of narcolepsy that have been caused by the vaccine for this H1N1 flu. So, as I mentioned, they used this adjuvant also in Canada, and initially they thought there was an increase in patients with narcolepsy in Canada. But the current feeling is that there isn't, that the cases that they found after the vaccine were just coincidental and that they're seeing a normal number of cases of narcolepsy in Canada. So that sort of shed a little bit of light. Well, maybe it's not just this adjuvant that's causing the increase in number of cases. And so now what's happened is that they shifted attention to the actual virus itself that was used with this adjuvant. And there's some recent evidence from Finland suggesting that the actual virus itself is different, and it's the virus that they used in the vaccine, the dead virus, that caused the increased number of cases of narcolepsy. This just is just an illustration that people are starting to think of how these things fit together, how this vaccine could affect the cells that are involved, including the HLA and the T-cell receptor, and cause chemicals to cross into the brain, causing destruction of the cells associated with narcolepsy. So the mechanisms of how this whole process is playing out to cause narcolepsy are starting to be understood. Incidentally, I also just mention that it's not just the vaccine that tends to cause an increase in cases of narcolepsy, but in China they've found that the actual virus itself, independent of the vaccine, led to a slight increase. Again, reinforcing a current feeling that narcolepsy may well be precipitated by some type of infective illness. So it may not just be Streptococcus, maybe viruses, maybe a whole host of different conditions, and we know that there are disorders of narcolepsy that tended to follow infectious mononucleosis, Lyme's disease, and other illnesses. So there may be many, many different infective illnesses that can trigger narcolepsy in someone who is predisposed to developing the disease. So our current feeling is narcolepsy is an autoimmune disease. Narcolepsy with cataplexy patients have the histocompatibility antigens. They have this T-cell receptor abnormality, and then it's possibly precipitated by an infection, causing destruction of those cells in the brain, causing narcolepsy. Okay, so I'm just going to finish briefly talking a little bit about treatment. And over the years, our treatments have changed for narcolepsy. We have moved out of the era of using stimulant medications for keeping patients awake, amphetamines, methylphenidate, although some of you, and I'm sure many of you, are still taking those medications. But in general, they're not regarded as first line. We now use medications such as the modafinils, either regular modafinil known as Provigil or armodafinil known as Nuvigil, and these are very, very commonly used in patients with narcolepsy for the sleepiness. And for cataplexy in the past, we used to use the antidepressants, particularly those that had a particular effect of blocking the uptake of a neurotransmitter called norepinephrine. And so medications such as Effexor, venlafaxine, atomoxetine, or Strattera are commonly used these days for the treatment of cataplexy. But there's a big variety of antidepressants that are used for treating cataplexy, and I'm sure many of you are on different antidepressants. However, sodium oxybate has now been available for 10 years. When it first came out, there was a lot of questions and concern about sodium oxybate because it was a sodium sulfur gamma hydroxybutyrate, which was a drug that had been abused. And so there was a lot of caution. It was relegated to sort of a third line treatment, that you used these, you did these things first, and if they didn't work, then you might go on to using Xyrem or sodium oxybate. Over the last 10 years, that's tended to change. And now we're seeing this agent, sodium oxybate, really becoming the first-line treatment for narcolepsy. And more physicians are using it first line. In a patient who has the REM phenomena, this drug is sort of moved up to being sort of number one in trial. And the reason for that is that people that have a lot of experience in using it have recognized that this is the only drug that will treat all the symptoms of narcolepsy. So there's no other drug that will do it. This will affect not only the cataplexy, the sleepiness, but some people have very severe and unpleasant dreams, sleep paralysis, paralysis upon awakening, hallucinations due to dreams that can occur during wakefulness, and disturbed nighttime sleep, and that can be helped with sodium oxybate. So sodium oxybate can be effective for treating all the features of narcolepsy. And there's no question that there are patients who take sodium oxybate where the effect has been absolutely dramatic, where they've had absolutely dramatic improvement of all symptoms of narcolepsy. Unfortunately, as with any other drug, there can be side effects with it, and there are some people who unfortunately are unable to take sodium oxybate because of side effects. But that also goes with other medications too, modafinils and the antidepressants. And modafinils can cause problems with very severe rashes, for example, that can be life-threatening and can interfere with oral contraceptive agents in women of childbearing ages. So there are problems in the use of all drugs. The antidepressants can disturb nighttime sleep. It can affect sexual function, and so nothing is perfect, but at least we have a variety of medications that are available to us for the treatment. But the big change, I think, over the last few years has been the movement of this agent, sodium oxybate, from being relegated as a third-line drug, moving up to really being a first-line drug, and those patients that can take it often can do extremely well with it. And very often what we'll do is to combine the sodium oxybate with either modafinil or the longer-acting form, armodafinil, so Provigil or Nuvigil. So often that combination, and the studies, the actual data that we have shows that this combination of sodium oxybate plus the modafinil seems to be the most effective in the treatment of narcolepsy. Just going to touch on something that I know is going to be discussed in more detail later on in this program, but just exciting and sort of sets the stage for it. But there are exciting new directions in treatment that may be coming up in the future, certainly nowhere near being available for human use at the moment. But I just wanted to bring your attention to it to show you that there are things on the horizon that could make dramatic differences for the treatment of narcolepsy. This is Orexin gene therapy, and this is in mice. And what we see here is Orexin cells in a normal mouse. And what they did in this experiment, and this was an experiment by Dr. Scammell, who's going to be talking to you later, and I'm sure he's going to go into this in more detail with you, that what they produced is they had mice who had a change to their genes, so they didn't have the gene or they didn't have the hypocretin cells. It was actually the cells for hypocretin were destroyed in these mice. So you can see here in this Orexin knockout mouse how there's no hypocretin present in the brain. And then what they did is that they used a viral vector where they added on the gene that produces hypocretin, pre-pro-hypocretin, which actually produces the two types, hypocretin 1 and hypocretin 2, because there are two forms of the chemical. And they injected it into below the hypothalamic region in these mice. And what they found that is after injecting this gene that they got a big increase in hypocretin right throughout many areas of the brain, not only in this slide you can see, but in other areas near the tuberculary nucleus, for example. And went on automatically. But so injections of this viral vector into the brain, and there are other studies also that have shown this now too. So there are several studies. The first study actually was done in 2008, but there are more recent studies injecting these viral vectors carrying the gene for narcolepsy into other areas and into the cells between brain cells, what we call glial cells, showing that if you do this, that you can produce hypocretin in somebody who's had a loss of hypocretin, and you can produce hypocretin continuously. So it holds great promise for the future. Then these types of techniques can be refined. And the good thing about narcolepsy is that for most people with narcolepsy and cataplexy, there's only one abnormality, or appears to be, just this loss of hypocretin. So compared with a lot of neurological disorders where there are many, many areas of the brain affected, there's a very specific abnormality here. So I think that narcolepsy holds some of the greatest hope in being able to find an actual cure for the narcolepsy, such as through these types of studies in the future. So I think the future looks very bright. So in conclusion then, narcolepsy and cataplexy is associated with this loss of this chemical neuropeptide hypocretin. Seems to be an autoimmune disorder, seems to be in people who have a predisposition to narcolepsy because of these genetic factors. Infection may be the most common precipitant for narcolepsy. Medications are getting better. Sodium oxybate is now moved to becoming a first-line drug for the treatment of narcolepsy. And future directions will involve that hypocretin, maybe through genetic means, or maybe chemicals that can replace hypocretin. And maybe by affecting histamine too may be a new direction in treatment. So I'm going to stop at that point, and I thank you very much for your attention. You want one burning question from someone? Okay. Okay. Yeah. The question was, can you have an MSLT without having the nighttime sleep study? Essentially no, because the interpretation of that daytime test is very much dependent on what you see in the nighttime study. So, for example, if somebody stayed up all night and didn't sleep at all, they could come in for the daytime test and they might have a positive test for narcolepsy. So you need to have that nighttime test to look at the amount of sleep, the quality of sleep, excluding other disorders, looking at the amount of REM sleep, so that you can accurately interpret the daytime multiple sleep latency test. I think I have to stop at that point. I'll be happy to answer any questions out the back, but thank you very much.